Alright, let's talk about thyroid disease in pregnancy. Practice bulletin number 223. So pathophysiology, thyroid gland is about 30% larger in the third trimester compared to the first trimester. The serum concentration of thyroid binding globulin also increase. TSH decreases in early pregnancy because of the HSG stimulation of TSH receptor. After the first trimester, TSH return to baseline and progressively increase. In the first trimester, TSH range can be lowered about zero point 0.5 from normal. After 16 weeks, is T4 level, the upper normal limit of T4 could be 50% higher than someone who's not pregnant. Fetal thyroid start producing thyroid hormone at 12 weeks. However, maternal T4 is still mainly used for fetal brain development. Overt versus There's overt versus subclinical hyper or hypothyroidism. Um, Universal screening is not recommended by ACOG only if patient has history of thyroid disease, if they have type 1 diabetes, if there's clinical suspicion, 30% enlargement of the thyroid gland is typical and does not warrant screening. TSH, free T4, if there's hyperthyroid, then you can check T3, total T3, but you don't check free T3. So for hyperthyroid, it affects about 20.5% of all pregnancies. 95% of them are caused by Graves' disease. Um, Fetal effects of hyperthyroidism, medically indicated preterm deliveries, low birth weight, fetal loss, transient hypothyroidism in neonates with women with Graves' disease, high risk of neonatal Graves' disease. Routine evaluation of fetal thyroid function not recommended. Subclinical hyperthyroid is not associated with any adverse pregnancy outcomes, and um, it's about 1% of pregnancies. Maternal effects, it can cause preeclampsia, sometimes it can cause heart failure. Treatment for hyperthyroid, usually we use PTU in the first trimester, then switch to methimazole. PTU crosses the placenta less. Also, mainly partially inhibits T4 conversion to T3. However, it does cause hepatotoxicity. Um, and due to that reason, it is switched to methimazole in second trimester. However, if T3 thyroid toxicosis is the main issue, then PTU should be preferred. Usually we start them 50 to 150 milligrams, divided into 3 doses. If you're trying to convert PTU to methimazole, we use a 20 to 1 conversion rate. Methimazole is associated with rare embryopathies such as esophageal atresia, aplasia cutis. It is usually used 5 to 30 milligrams BID. Taking thiamides, there can be a transient leukopenia in 10% of patients. Medication do not need to be stopped. 1% can develop agranulocytosis. So if patient experiences fever or sore throat, we need to stop the meds and get a CBC. We monitor free T4 with patients on thyroid on the thiamide medication. We try to maintain the free T4 slightly above normal. Monitor every 2 to 4 weeks. T4 is the measurement for hyperthyroid. Beta blockers can be used for palpitations. You can use propranolol 10 milligrams TID. Fetal ultrasound for goiters or growth. Antenatal testing. And these patients should be delivered at 39 weeks. For hypothyroidism, it affects about 1% of pregnancies. Hashimoto thyroiditis is the most common cause of hypothyroidism. Daily intake of iodine is about 220 micrograms for pregnancy and 290 micrograms for lactating women. Adverse effects of hypothyroid: spontaneous abortion, preeclampsia, preterm birth, placental abruption, fetal deaths, impaired fetal neurological development. Maternal thyroid inhibitory antibody do not cross the placenta or cause fetal hypothyroid. Subclinical hypothyroid do not require treatment, and this affects about 5% of pregnancy, while subclinical hyperthyroid is only at 1%. So the incidence of hyperthyroid is lower than the incidence of hypothyroid. So 0.5% of pregnancies has overt hyperthyroidism, and 1% has subclinical hyperthyroid. For hypothyroid, only 1% of pregnancies has overt hypothyroidism, and 5% will have subclinical hypothyroid. Treatment: you start them on Synthroid, 1 to 2 micrograms per kilo daily. Usually, you can give around 100 micrograms. We can adjust the dosing based on TSH, not T4, and TSH should be kept less than 2.5. We monitor them every 4 to 6 weeks. Patient already on Synthroid should increase the dose by 25% when pregnant. Testing for TPO or thyroid stimulating immunoglobulin has not been shown to change medical management or affect fetal outcome. TSH is the most reliable indicator for thyroid status because it indirectly reflects thyroid hormone level as sensed by the pituitary gland. T3 rarely causes symptomatic hyperthyroidism if the T4 is normal. Hyperemesis, TSH receptor hyperstimulation. So we have a increase in T4. TSH may remain suppressed for several weeks after free T4 returns to normal. Gestational transient hyperthyroidism, low T4, low TSH, high T4. Measurement of TSH is not recommended unless there's other signs of hyperthyroidism. Thyroid storm. 1% of pregnancy patient that has hyperthyroidism can develop thyroid storm. This can lead to heart failure and pulmonary hypertension due to excess in T4. This is reversible. Symptoms, we have a sudden onset of fever, high fever, 103 Fahrenheit, tachycardia, cardiac arrhythmia, central nervous system dysfunction. Usually there is a triggering event if the patient developed preeclampsia, anemia, or sepsis. Level of T4, T3 does not correlate with the severity of the disease. Treatment, we're basically trying to stop all routes of T4, T3 production. So we give PTU 1 gram or 1000 milligram PO, and then 200 milligram POQ6. We give iodine 1 hour after PTU. You can use NA iodine 1000 milligrams IV Q8 or Lugol 10 drops by mouth Q8. We block the conversion peripherally with hydrocortisone 100 milligram IV Q8. We can give propranolol or labetalol for tachycardia. Fetal thyroid toxicosis in the setting of maternal hyperthyroid. We see fetal high drops, IUGR, fetal goiter, persistent fetal tachycardia, fetal thyroid toxicosis. Cancer of the thyroid, ultrasound can detect nodules greater than 5 millimeter. 2% of all reproductive women has thyroid nodules. 95% will be benign. We see a hyperechoic region with irregular margin, microcalcifications. These are suspicious for cancer. Radioiodine scanning is not recommended in pregnancy. Fetal thyroid gland is not functional prior to 12 weeks. There is no risk of damage if radioiodine exposure. Thyroidectomy may be performed before third trimester. However, there is a concern for accidental removal of parathyroid gland. So if the tumor is not aggressive, surgery can wait till after delivery. Postpartum thyroiditis, up to 12 months after delivery. Transient autoimmune thyroiditis can be found in 10% of women during the first year of postpartum. 10% is very high. We see two phases of postpartum thyroiditis. First phase is a destruction-induced thyroid toxicosis. We have fatigue, irritability, weight loss, palpitations. We see a small painless goiter. It lasts a few months. We treat only for symptoms with beta blockers if the symptoms are severe. Then we can see overt hypothyroid after 4 to 8 months postpartum. If the patient develops postpartum depression, we can screen for TSH. That's it.